gave a great talk. Prisco gave a wonderful talk, but unfortunately some of her slides were cut off at the end. And so she's in an airport, so she's doing double duty, trying to get on a plane, and we'll let her speak, present the last couple of slides that you weren't able to hear before we discuss. Prisca, please go ahead.
Okay, thank you. I'm so sorry. Apologies about that. And good enough, I have just 2 slides more. The last slide that's froze is the slide on challenges. And the challenges include bottlenecks in integrating genetic services to patient care. I don't know whether the noise here can allow you to hear me. Are you able to hear me at all?
Yes, you're good. Thank you.
Okay, that's very good. So I was talking about the last slide that froze, and I said it's talking about challenges. On the challenges, we had initial bottlenecks in integrating genetic services to the patient care because some of our colleagues felt like, what are you guys doing? Are you crazy? I mean, what is this? The patients are here for some things, you are doing some other kind of things with them, and they didn't quite understand. And of course, some people felt like, are you paid for this? Is there a different salary that you're going to get for doing this? And we said, no, we're just volunteers. And that's what we've learned from our mentor and from other places that we have had privilege to be, that you volunteer and you do the best for your patient as much as possible. And the non-availability of central service center. We, in our setting, the care for cancer patients is actually not centralized. So you have patients coming in through pluralistic means, and that created a kind of chaos and difficulty in really getting the patient together. Of course, inadequate support from other colleagues, like I've mentioned, even some of our own colleagues ask you funny questions. I'm just wondering why you're committing so much time to this. What do you want to get out of that? And then, of course, delayed ethical approval in some centers, leading to delayed recruitment for research component. We experienced that in one of the centers where they felt like, what is the essence of all of this that you want to do for our patients? And if you want us to really actually do this, are you going to be able to say that, well, we're going to obtain consent, and then we say we are rendering service. Okay, if you're rendering service to the patients, what are they going to benefit? We say we're bringing kits, and these kits cost $250, and our patients are not going to pay for this. Okay, that is fine. But then we have to pass it through ethical approval. And so as long as there's a delay in obtaining the IRB, we cannot commence anything in such facilities. And then low level of compliance to standard operating procedures in collecting samples in some of the centers. We actually found that a few of those samples could not pass through quality control, and so we had to organize refresher training in such facilities because we don't want wastage of the kits at all. And then the COVID-19 pandemic was another challenge, and was a big one for that matter, in the sense that it started like a joke, and we all experienced it in various countries, and until total lockdown came, and we actually had some of those samples expired because there was nobody coming to the clinic. We're not seeing patients. We couldn't obtain sample, and those kits had expiry dates, and of course, they expired on our hands. That was one of the challenges. So what we did was to pack them up and stopped collecting data at that point, and then that ended the first phase. By that time, we've seen about 400 patients, and we just transited into a new project, which is the GenCaf that that you listen to in the course of the video earlier on. Let me quickly go on to the last slide so as not to take too much of our time. The next slide talks about next steps. What are we going to do? I haven't experienced all of this. The first thing is to pursue integration of genetic services to patient care, synchronize genetic services and risk management as much as possible, enhance patient navigation, which is something that is missing in our environment. You see patients moving from one end to another end, and like I've said, they are in different angles and different centers. So we want to try and see if we can put all of this together and have the patient's navigation system in place so that it makes life easy for these patients. Creating a culturally tailored cancer genetic risk management algorithm, and then conducting refresher on NCCN guideline. As the changes are coming, we hope to be able to actually meet with the providers, run a refresher course, and be sure that we are all on the same page and up to date as we got various changes that are on the NCCN guideline from time to time. And then, of course, we want to expand to other African countries. This year, we have had an extension to Cameroon. With the help of our mentor, Professor Fumi Olokpade, we extended the training that could have been a face-to-face thing, but again, due to COVID, we had to turn into virtual training, and we had that online. And then upgrade from paper and pencil pedigree drawing to progeny. Like we have said, we have seen in the, when you were listening to the video, you saw where nurses were actually drawing with paper, and it works for us in our environment, and that's what we've been doing. But I informed us of the need to fund opportunities to have progeny license. We're actually, looking forward to doing, and then transform hard copy genetic album to electronic tablets. We hope that is also going to be possible. And that is the end of the presentation. The next slide is acknowledgements, just to thank all the people who are fantastic, who have been doing incredible things like the Color Genomics Laboratory that has been existing for us, our mentors, Professor Fumi Olopade, and all down everyone. The last slide here talks about all of these being Herculean tasks, looking very difficult and complex, right? But I said, yes, we can. And of course, I said, thank you very much for listening to everyone. Let me acknowledge our mentor, Professor Fumilayo Olopade, very profusely. She has done tremendous, and she's still doing. And let me thank a mentee, Mrs. Toyin Aniago, who is also on this call tonight, who is listening also to me. I believe she's here. And of course, thank all the team members who in one way or the other are participating. There are so many pharmacists, doctors, nurses who are in this team. I want to appreciate everyone and say I'm just presenting on behalf of the team. So thank you very much for the opportunity. Thank you so much, Team Rebek, for this opportunity, and thanks to others. God bless you. Over.
Thank you, Priska. As you all see, Priska is a dynamic force in this field and has made incredible headway in developing the field for Nigeria and for Africa. And she's really a doer, as you can see by being in the waiting room at the airport giving this talk. So we really appreciate Priska and her contributions. So on that note, I also want to notice that we have a number of panelists here today who will help answer questions. These include Achille Menarakiza from Rwanda, Annette Uwineza from Rwanda, who you just heard a little earlier give a presentation, and Dayo Fadelu from Boston, who are all three clinical and genetics experts. And Priska will be on for a little while till her plane has to take off. So welcome to the panelists. And we already have a couple of questions that I'd like to start with. And I don't know if Priska, you're still there and able to answer, but I think you all already did say a little bit about whether you have cancer genetic testing in Nigeria, and if not, any plan to have one. I don't know, Priska, you talked a little bit about this. Can you say a little more about your testing protocols?
Yes, thank you very much. We do have testing, and the opportunity that we have is what I introduced earlier on with Color Genomics. Color Genomics is a laboratory that works in partnership with our mentor, Dr. Fumi Olopade. So the kit is a $250 kit, but it's free for our patients in the hospital. We started in 2018 to save patients using these kits, color kits, and Color Genomics is a laboratory that I'm referring to. So what we do is we collect the sample here in various hospitals in Ibadan, in Lagos, Luth, and the various training centers, and the samples are shipped. So we actually have a plan for shipment, and we ship it to the US, where the results is analyzed and sent back to us, and disclosure done by this group of people to the patients. I don't know whether you can hear me with the announcement.
We can. That was great. Thank you.
I don't know whether you want me to talk more about the 30 gene hereditary cancer panel.
If you would like to, I'm sure people would be interested. Yeah.
Actually, we were able to discover mutations in four of those genes that I presented during the video. But the test, the color genomic test, has capacity for 30 different genes, apart from those 4 or 5 that I mentioned. So we have BRCA1 gene, BRCA1, BRCA2 gene, we have MLH1, MSH2, MSH6, PMS2, EPCAM, we have APC, we have MUTYH, we have MITYP, we have BALP, we have CDCAN, we have a P10, we have a TP53, we have different kinds, up to 30 of those genes. And of course, we have about 8 different cancers that can actually be attended to, even though majorly we have seen patients with breast cancer, but we've seen with ovarian and uterine. But with that kit that we're using, we actually have opportunity for other genes, other cancers like colorectal cancer, melanoma, pancreatic cancer, stomach cancer, and of course, prostate cancer. So thank you. It's Color Genomics that is responsible for that, validated with very high sensitivity report that we've obtained so far.
Thank you, Priska. I don't know if you have time to answer one more question. There's one question here that asks, how did you manage the challenge of getting accurate family histories for pedigrees, given that most people don't know the details like diagnosis, age at diagnosis, and death. Do you have how have you dealt with that?
I didn't get that question, but I think what you are saying is whether we obtain history from the patients, and the history that you receive from patients include things like what you have mentioned. You want to find out from the patients and take history concerning the kind of cancer that exists, on what kind of parent, what kind of family, paternal or maternal, what's the age of onset of the cancer, if somebody has died, what is the age of death of that person. So we have all of this information from the history that is obtained from the patient. So if I get you clearly, you are asking whether when they don't have access to that information, they do. I'm just saying that in my environment, generally speaking, people die of after brief illness. So it's not like as it is done in developed countries where you have detailed history from the patients and you have access to lots and lots of information. But that notwithstanding, we are trained and we train others to actually obtain all of this history from the patients.
Yeah, that's great. I think that there's a lot of practical knowledge that's difficult. And what we found, at least in the US, and maybe this is something that can happen in other settings as well, is to use the family members. So many times family members, there's always someone in the family who kind of knows what's going on. You know, there are people who keep track of who's sick with what and who died and all of that sort of thing. And sometimes it's the patient doesn't know all of this information, but one of their relatives who keeps track of this information does. And so sometimes what we do is have the patient or the person who's being interviewed go back to their family and ask these questions. And oftentimes that information can be found. It's always a question of how accurate it is. And obviously, if you want to confirm cancer diagnoses and things like that, we rely on medical records, and those just may not be available. But certainly using family networks to capture some of this information can help. So great. Another question that's come up, and keep putting them into the Q&A. Samuel Guai is saying that he feels that there really need to be more genetic testing centers. And what is an approximate estimation of the cost for establishing a cancer genetic testing center? And I'd like to hear from some of our panelists about that. I don't think anybody's going to have a great answer. Maybe Krista, since you've done
no, we don't have an idea of how much actually. But the point is, where there's a will, and I want to talk about the opportunity to have access to grants, to have an opportunity to partnership. Like I told you, is a mentor that connected with Color Genomics that supplied the kits, and she paid. So it's not free even though our patients are not actually paying, but the truth is that someone somewhere is paying for it. So what I'm trying to say is that I don't know how much if we're going to be paying out of pocket, I don't know how much it's going to be. It's very difficult to say for me. I don't know, maybe others will be able to say that. And I'm sorry, I have to run out of here now.
Okay, yeah, don't miss your flight for us. Thank you so much for contributing. We will obviously be in touch with you, and I know there will be many other questions. So good luck, safe travels. Talk to you soon. Bye. So let's follow up with that a little bit. I don't really think we know what the costs are, but do any of the rest of you have any comments about cost and setting up? I think we could think about what the costs might be without putting actual monetary sums. So for example, we can imagine there will need to be clinicians, there might need to be space, there need to be facilities for biosampling, blood draws, shipping to genetic testing companies, the costs of actually testing, and then of course there are all the medical management costs. But does anybody else want to comment on that on the panel?
I wanted to add a couple of things. Dr. Adejumor had mentioned the samples were being tested outside the country. So just thinking about ways of collaboration. So even if testing capacity isn't present in country, there are means of either collaborating with institutions like Color or with perhaps other centers in other parts of Africa that might have in-country testing. So just putting a plug in for figuring out ways of collaborating between countries.
Yeah, and I think I would also make the point that in the US and Europe and other places, nobody does their own homegrown testing. All of the testing essentially these days is done by companies. And that's largely because companies have the technology and the capacity to make these tests that are accurate. They have the quality control and the curation of mutations and all of that kind of work that is really hard to do. It's really expensive and it takes a lot of energy. And so almost nobody develops this themselves. And so there are a couple of companies in Africa who are beginning this process. 54Gene and Artisan Biomed and a couple of others are African companies that are developing these processes, as well as you've heard Color Genetics, Invitae, GeneDx, and other national, international companies. So I think that one of the things to consider, at least in terms of setting up a program, is that you're probably not setting up your own lab. You're not using local laboratory resources to do sequencing. You're probably figuring out to keep it at the standard of what everybody else in the world does. You're talking about using genetic testing companies. So the question is, how much does that cost? Right now in the US, a full gene panel costs about $250, which is a lot in Africa. And it's coming down, the cost is coming down. And the panel varies in size and the number of genes, but the cost doesn't really vary a lot. And so then there's shipping, which often is free. And in fact, a lot of companies, if someone in the family tests positive for a gene, so you have a patient, they pay a $250 fee to test for the genetic mutations, and they find one, a positive, their relatives can be tested for free. In many cases. So that is to say within a certain time period. So if you get relatives who you want to establish whether they're also at risk, whether or not they have cancer, sometimes that testing is actually free. So there's a lot of issues like that that one can consider in thinking about the cost to the patient and the cost to the development of the center. Anyone else want to add to that discussion?
Yeah. Yes, I'd like to add something on that. So I think what we can gather from everyone's contribution is that essentially you really can't start big and to say that you'd be having a program that touches pretty much all the malignancies. You'd rather start small with a few low-hanging fruits, if I may call them like that, and build up slowly with the larger program after that. So beyond the fact that everyone will use companies, the question remains around how to translate that into clinical practice and also how to translate that into a policy. And later on, how do we advocate after showing how much of a burden it is? How much do we advocate towards getting all the tests done under insurance? So in many countries in Africa, it's a paper that we've been working on. In many countries in Africa, chemotherapy itself is not paid by public insurance. And how are you going to translate a program that costs, say, for a patient about $250 in Rwanda? For patients who have been getting it, they used to pay between $1,000 and $1,500 to get the test done in Belgium. You really have to think very long and hard on how you're going to change this into a sustainable practice that is also backed up by insurances. So that the answer really is start small, build up capacity, and beyond that now, do as much as you can to translate whatever you're doing into a sustainable practice that is also backed up by insurance to enable many patients to access to it. Thank you.
Thanks. And there's a couple questions in the chat. I just want to make it clear what the test is we're talking about. So generally these days, the genetic test involves spit. It involves saliva. It can be done with blood, but many of the tests are in spit kits. So the patient will spit into a tube that contains a preservative, and that saliva will then be shipped, and it's stable at room temperature or whatever travel temperature it is. And so it's a saliva sample that's used then for genetic sequencing at for a panel of genes. And the panels do vary. The more common large panels include 84 genes, but there are 36 gene panels. There are many different panels. And so the test is fairly non-invasive. It is relatively easy for the patient to use. In many cases, it's done right in the clinic, but in situations where that's not possible or where the patient may be seen virtually, the kit can be mailed to the patient and their relatives, and the patient has instructions about how to spit into the tube and then set it out for mailing to the testing company. In many cases, the shipping is free or it's already paid for. That is something that is variable if you're in Africa, but it's something that can be negotiated. So these are the kinds of, just so that people are clear about what kind of testing we're talking about. So if you can have other kinds of questions about testing, let us know. We'll try to give more detail about that. And certainly in the next lecture, when we hear from the Invitae group, they'll talk a little bit more about this. Any other comments from anyone on those topics so far? So Francis Makoka is asked about the study in Nigeria that Dr. Olopati and Adejumo led, among others, that were suggestive of aggressive cancer in Nigerian women compared to African-American women. And he says, I think that could be population-specific mutations driving cancer in Africa that may not be included in probes on testing platforms. So a couple things to think about. One is, yes, there is some suggestion that breast cancers and other cancers are very aggressive in African women. And the question is really, is that are there inherent biological drivers that are stronger in Africans than in other populations? Or are these patients just coming to attention very late? And this is a question that I don't think we know yet, but certainly the pattern of cancer that is seen tends to be quite aggressive, and it is likely to have some kind of biological driver, because the patterns of disease, like in breast cancer, are quite different than in non-hereditary or in the US or Europe. And so there's a lot of issues like that suggest there are very different patterns of disease. When we talk about the mutations that drive cancer in Africa, it's very possible that there are mutations that are unique to Africa, and those may be may provide more aggressive or poorer prognosis. But those mutations should be detected on the testing platforms, because the testing is done by sequencing, meaning it's not just looking for known mutations, it's looking for any mutation that exists. So because they're sequencing and complete mutation detection, those mutations should be detected. Now, the question of whether those mutations will be defined as pathogenic, sometimes there are variants of unknown significance or VUSs, and we're not quite sure what to make of those because they haven't been completely studied, they haven't been completely characterized. So there's definitely a higher rate of these unknown variants or undetermined function variants in populations like Africans, because they just haven't been studied as much. And so there is certainly misclassification that will get better once more information is available, more data are available. But it certainly is likely they will be detected on the test. So that's just, anybody want to add to anything of that? So there's a couple of questions here about collaboration and developing programs, and that's exactly what our African Oncological Network group, who's sponsoring this educational piece, is trying to develop. And so we will certainly, all of you who have registered for this course will certainly be in the loop about future developments. But if you do have questions about specifically setting up programs or want a specific kind of training or additional interaction, let us know. You can send emails to the africanoncogenetics@gmail.com or to me or to some of the others on this panel, and we can provide you with more information, and we certainly will connect you with the group in Ibadan and others. So those are things that we will certainly facilitate. And I think it might be useful. There are a number of questions about sort of setting up testing, setting up these programs. And we're now developing through an NIH-funded grant a pilot proposal in Rwanda that's led by Drs. Uwineza and Manirakiza, who are here. So maybe Achille or Annette, do you want to talk a little bit about your pilot and what it's taking to get the program set up locally in Kigali?
Hello, good evening.
Hello.
So this is Annette. I want to, can you hear me?
Yes, we can hear you, yep.
Yeah. In my presentation, I talk about that in Rwanda, we have set up a Center of Human Genetics in 2006. But most of our patients are not about cancer genetics, but I think that the experience is quite similar. The challenges we have found, because when we set up our lab, it was a grant from with the Belgian corporations, but at that time we don't have the community-based health insurance was not yet set, so people has to pay from their pocket from the genetic test, and it was very expensive, but now they are included in the package of the health insurance, and people are paying. We have seen an increasing in the number of people requesting from genetic testing, but the challenges I have seen when we set up such kind of infrastructure in our country, especially when it starts from a grant, it's when the government is not involved or other stakeholders have other priorities. You have the startup kit, you have the equipment, but after, when the grant is over, you don't have maintenance for the machine, you are not able to buy the equipment, and it's like what you have started is start to break down. But when the government is committed, now the government Rwanda is committed to invest in cancer, I think that the big part is the investment of the governments. Because also there is also, it will also need the training, the lab technician, the clinicians, also even the awareness, because even the clinician, you will find that even your colleague, they don't understand or they don't agree to refer patient for genetic testing. So I think it's a whole system that we need to build. But first of all, with a positive impact, for example, with the COVID, is that people have started to understand what is gene sequencing, the relevance of sequencing. And I think that also this will have a big impact in genetic testing, developing genetic testing in Africa. So in summary, we need many people to be involved, especially the government.
Thank you, Annette. And I would argue that one of the strengths of the Rwanda situation has actually been cooperation among multiple sectors of the government. So it wasn't only the Ministry of Health, but the Ministry of State that were involved in the conversations, the Ministry of State being, the people that pay for things, as well as the Ministry of Health, which organizes the health services. And so just to say, I think Annette's point is really important, that it's not just one set of people. It's not just the clinicians who need to do this. It's policymakers, government, it's education, various ministries, maybe educational ministries, ministries of state, ministries of labor, many other groups. It might involve business, including genetic testing companies. It might involve NGOs. And I would just say that it's really important both to have a system and a pipeline in place, but also to have all the stakeholders at the table. Achille, did you want to add anything about or Dio?
Yeah. Certainly want to add about the program that we have. I think you asked a question about it. The way we're setting it up here. So we have a subset of a grant, NIH grant, to essentially do a pilot around breast and prostate cancer patients. So essentially doing the genetic workup of the patients. So we have a sample size close to 400 patients, 200 patients of breast cancer and 200 patients of prostate cancer. What we're trying to do is to have a few of the patients with, eligibility criteria, mainly, let's say for breast cancer, young patients or patients with a family history, patients with triple negative breast cancer, pretty much all the eligibility criteria that you have in other countries that have been proven before, test them for breast cancer. Genetics around, the genetics around breast cancer. Now, the question that we've been having essentially now is, I think there is a question related to that, is a question about data protection. So, and it's something that is quite uniform across Africa. We don't have what they call in other countries at the GDPR. So GDPR stands for General Data Protection Regulation. We don't have that, and while not having it, it means that whoever gets our information out there can use it for whatever reason they want. So that touches the ethical part. It touches the very private part of information of the patients, but also to many places, at least in our country, it is also a security matter. And also that goes into the implications of the study. So you really don't want to do genetic workup when you're not proposing anything. And to also answer a question that was asked, I was scrolling through the Q&A, there is a question about the cancer-free individuals that come from the family of the patients, the ones that are tested for free. We will certainly have about 2 blood relative of the patients coming and to be tested for free. These are individuals that do not have cancer that will be tested for potential, genes that could potentially lead into cancer in the future. What do we do for them? So those are the questions that we still have to answer. We do not want to get only information if you don't have anything to do with them. So we have a few partners that would provide medications. We have surgery available for patients who have the risk, for individuals who have the risk to develop, let's say BRCA1/2 positive breast cancer, who would need mastectomies. We have pretty much everything available and in place. So whenever you want to set up a program, I think I've mentioned it, you have to think in wide terms, in terms of what you're going to do with the data, what are you going to propose to the patients, and also the data that is out there, what are we going to use it for? Is it protected? Are the patients that allowed you to get the test done, are they protected? And what are you going to do for them? Because at the end of the day, all this testing is not for whatever publication without protecting the patient. The patient is the sole source of information, but also they have to benefit from it. Thank you.
Yeah, thank you. And your comments address directly a question by Samira Dalvi, who says, what are the ethical implications of doing genetic testing, but not having the resources to follow through with the results? So for example, colonoscopies or chemo prevention, or for people who have cancer, the targeted therapeutics that might be unavailable. And I think your point is exactly right. I don't know if anybody wants to add to that, but I think there are ethical implications of doing genetic testing and not being able to act on those results. Any Dio, or did you want to?
Yeah, I wanted to add a couple of things. I totally agree with those points. I think one potential approach is, it's not necessarily an all or none situation. It's not every place might have every single thing that you need, or every single thing that is, say, might be done in a higher resourced place like the US. But for example, there are things that are available, mitigation strategies that are already available in many African countries. And I think Eshil mentioned a couple of them. So the availability of surgery, the availability of monitoring by imaging, either imaging with ultrasounds or mammograms. The availability of colonoscopy might not necessarily be widely available for population screening, but might be available for people who are identified to be high risk. And I think another element to this as well, which Ashil has mentioned, is some of this also allows for advocacy for payers, because being able to recognize someone who is high risk and giving that person the preventative treatment that they need certainly can save payers in the long run. And the payers could be, national insurance scheme or private insurance schemes. Having some of this information, I think, can certainly push the envelope on what things payers might be willing to pay for with regards to preventative screening in high-risk populations.
A great point, Dio, and I think that really addresses the comment that those of us in the field, those of you who are listening, have an opportunity to educate your health systems, your ministries, your other colleagues in your countries to help understand the value of prevention, the value of genetic testing, et cetera, because these are things that do require some active participation on your part to help convince people that this has value, that there is added benefit and gain. And I think it's really important, particularly because so much of medicine in the world is becoming genetically based. Precision medicine, genomics, and Africa should not fall behind in having access to these important tools. And it's a difficult message to make, but I think it's one that we as a group can try to create educational platforms to educate those people who make decisions and pay the bills. So another thing that was a follow-up from Dio's comment that he sort of alluded to, but is a question from Samuel Guai here in the chat. He says, genetic testing is mostly for heritable cancers. What can be done on non-heritable cancers? And is genetic screening the same as genetic testing? So one point to make, first of all, is that in fact, genetic testing has been traditionally in cancers that look to us like they're heritable for some reason. There's a family history, they're early onset, they have certain kinds of characteristics. But as we start doing broader and broader testing, we find that a lot of the genetic test positive cases that we see have no family history or are not diagnosed at an early age. So the scope of who has one of these mutations is actually much wider than we originally thought it was. And so it's not an answer to this question, but what it's really saying is that we often find mutations in people we didn't expect to see them in, non-heritable cancer settings. And in addition, we're also starting to see mutations that we didn't expect for the kind of cancer. So we'll often see a breast cancer family that looks very heritable for breast cancer. And when we do the panel test, we find they have a mutation usually associated with colorectal cancer or something else. And so I think that it's a quickly evolving field, and it's something that there's a lot of new knowledge coming about now about what testing is good for, who should it be used in. And so I think that that's really something that we need to give a lot of thought to, and we'll hear from the others in a second. And just to your point about screening and testing, I mean, these are important distinctions. Screening is usually thought of as something that happens in a larger swath of the population to sort of understand what's going on. Like if cancer screening, you pick people that don't have a cancer yet, at least as far as you know, and you try to identify the cancer. So that's screening a large population. In genetic testing and in genetic screening, it's also kind of similar. You want to screen large parts of the population who you think may be at risk. So there are examples of this. For example, in Ashkenazi Jewish populations, there are known founder mutations. And so it's been proposed that because there are essentially 3 mutations that are found in this population, a 3 mutation screen should be given to everybody because the mutation screening is simple. It's three mutations, and 2.5% of the population carries these, so it's fairly common. So in that case, screening is something you would do in an unaffected large segment of the population who might be at risk. Testing is more specifically, at least in my definition, the action itself. You apply a genetic test, and that could be in an unaffected person. It could be in an affected person with cancer, and you're testing them to figure out what their risk is or what drugs they should be using based on that mutation, et cetera. So again, the words are not always used properly, but there are distinctions. Does anybody want to add to that? Or not? That's fine. So just sort of going through these in no particular order, there is a question here about a person being tested and positive for a genetic mutation prone to cancer. Do you see that as easy to accept? How do you manage those cases if they panic and develop and are worried? And so I'd like to hear from the clinicians who see these situations, but I think that the point is a very important one, that there are psychosocial implications for genetic testing. And that's why there are genetic counselors. There are people who are trained to deal with the counseling, the social, the psychological issues related to the genetic test. And that's a different skill set, although some MDs and nurses may have those skill sets as well, but it's a slightly different skill set because it really manages those, the anxiety, the worry, the other issues around their people who are concerned about their cancer risk, et cetera. So the counseling piece of this is really important, and it's critically important that we develop genetic counseling more broadly. And so in the next week's session, that session is going to be entirely on these issues and related issues about counseling and how you deal with that. Does anybody else want to comment about the psychosocial issues and the patient issues?
I want to add that I think those sort of highlight the importance of if a place is going to be trying to establish or start doing some form of genetic testing, doing it in a very controlled way, in the setting of, you know, a program where you've sort of thought about all of these things, as opposed to just, you know, offering it willy-nilly without thinking about all the potential consequences. I mean, I think that's one of the, you know, benefits of the program the Rwanda team is trying to start now is it's being done in a small controlled way, such that as these issues arise, there is a systematic way of addressing them. And I think it's also sort of important to sort of think about implementation science strategies on how to, you know, help people adopt recommendations that are made after they might get a positive test or whatnot. And I think many of these things will be quite contextually specific to that specific area because of different cultural and social attitudes. And I think, you know, it really needs to be done in a controlled way, I guess, is the main point.
Yeah, great point. And I think that I encourage you all to attend next week's 3 sessions, because these are going to be led by genetic counselors. They're going to be led by clinicians who are directly involved with patient care in this setting. And they will bring both the general principles and some practice guides, but also some examples of how you deal with patients when they have genetic risk, or if they're anxious or worried about their risk, or whatever it is. And so next week's sessions will really help all of you to understand how to deal with this in your practices, in your local setting. Achille or Annette, anything to add, or should we move on?
Maybe my comment is that for genetic counseling, it's why the pre-counseling is a very important step. And also in our context in Africa, in my presentation, I talk about the challenge in patient understanding the aim of the test. And sometimes when you give them the result, it's when they start to realize the severity of the condition they have. So it's why when we conduct a genetic test, we need to do pre-counseling and post-counseling. And in other settings, they have also social psychologists or other nurses who are trained that will help the patient to deal with these situations.
Thank
so
you.
It's why maybe implementing genetic testing, it's a challenge, because in addition to the equipment, to the test, you have also the genetic counselor. All those people will deal with these issues.
I think we have a potentially great idea for another paper as a subset. I usually receive patients who come for voluntary screening. For one reason or another, they feel they know the age, they have the information about getting screened for breast cancer. But this is a whole new population that we're going to look for. The ones that are not patients, the ones that are blood relative to the patient. And it's going to be quite interesting to know how they receive the news. And this is a totally new territory for all of us, really, at least on our side in Rwanda.
No, I think for everyone in Africa, because the literature that's out there on these topics is really largely based around, the US, Europe, places that are culturally and socially quite different than Africa. And so while we can imagine what some of the features may be similar, there are absolutely going to be much larger differences. So you rightly point out that there's a great need for the counseling, biobehavioral, social studies, psychological evaluations, et cetera, to understand how people understand and use this information. And, I think in particularly in genetics, which is different than other areas of medicine, it's not only the patient that is influenced by this knowledge, this information, but their family members. So if an individual has a mutation that causes them to have high risk of cancer, that implies that their relatives, their biological relatives, may also carry that mutation. And so it becomes a family network that's important to consider, not just the individual. And again, in the United States and Europe, there have been many studies about the relationship of families and how an individual with a mutation relates to their family about this information. But undoubtedly, that's different in Africa because the social settings, the family settings probably vary. And there are issues that just are not understood. So you will get a little bit of that again next week, but I think it's a great area of research for anybody that wants to pick it up. Great. I just want to mention again, there are a number of questions here about putting people in contact with each other and how do I get testing and how do I do this in my setting? And that's what we're here to do. I'm glad to put you in touch with Dr. Manarakiza and with Dr. Adejumo and others. So email us and we'll be able to try to link you up for the questions that you have, your common interests, and try to build a network of people who are interested in discussing these questions and building up the local capacity. So a couple of questions about that are maybe sort of logistical in nature. One is by Shivani, says the private sector in South Africa inflates genetic testing costs and guards the market. To establish a testing center, they need to, that's a barrier apparently. Another one says in Africa, where biosecurity is held high and is not easy to ship samples outside the country, how do we tackle this? And these are logistical issues that are not trivial. Certainly a lot of this depends on local laws and regulations. And there are situations, so many of the genetic testing companies do ship samples in and out of lots of different countries. And so they have a lot of experience dealing with the regulations, the laws, the export permits and regulations for biosamples and things like that. So these are things that can be dealt with, and the companies know a lot about it, but obviously it's something that is very difficult for an individual practitioner to manage. So this is something, again, a network working with companies that do this work probably needs to discuss, and something we can do. But I would love to hear from the panel about issues around cost, the private sector not helping this process, the shipping, other issues that are sort of logistical that you can think of, or maybe you have ideas about how to solve.
Yeah, I think fortunately or unfortunately, a lot of these logistical issues are going to have to be tackled, you know, on a country by country basis. I think some suggestions around, you know, advocacy within the Ministry of Health and having folks with at the Ministry of Health at the table when conversations about you know, establishing something new like genetic testing is going on. And I think you know, many African countries now have national cancer control plans, and there are elements within those cancer control plans that might be applicable to, you know, ensuring that adequate testing for a variety of cancer-related things are available. And I think that's one potential avenue for advocacy. Obviously, the type of sample that is being shipped also does matter. There's the rules around shipping blood are very different from the rules around shipping some other things that are not necessarily directly infectious. So being sort of innovative in what type of sample can be shipped, I think can also help facilitate some of this availability of the testing. I have no experience with the private sector, so I don't really have any comments on, on that. But it would be great if there were some, you know, engagement from biomedical private sector and technology sector within Africa to sort of develop some capacity within the continent. But that's beyond my my level of expertise.
We'll certainly hear more when a person from Invitae comes in. But the experience here is that the price is usually span between $200 to about $700 a sample to be tested. And the shipment part, you usually get an agreement with the laboratory that is going to work on it. And the price is comprising also, well, of the shipment. Blood, as Dayo just mentioned, blood takes a lot more processing than any other sample. That's why we all resolve to use spit, and spit uses, you know, only needs room temperature and doesn't need a lot more, you know, processing. It's ready to be shipped and can go. But the question remains about the quality of the sample that is going to be used. But whenever you get an agreement with the company, the shipment is also covered in every sample that you, like the money on every sample. So that shouldn't be an issue. And they also, the company that we are in agreement with they usually just send you also the containers for the sample. So I think this would respond to all the logistical side of the questions.
Yeah, thank you. And a good point. Tomorrow, a lecturer from Invitae will present some of this, and I would re-ask these questions to them if they're here. They will be part of the discussion because I think some of this logistics, some of the sampling, sharing, some of the shipping, some of the cost issues are things they've thought a lot about and have answers to. They may not be great answers, or they may not be the answer you want to hear, but at least they will be able to tell you the lay of the land. And so you can learn a lot more about that tomorrow. We just have a couple minutes left, but there's a few questions on sort of the ethical data protection, confidentiality, and I wanted to spend the last couple minutes on that. One attendee says there's a new data protection and regulation law in Nigeria that mandates data protection for organizations that handle personal data. And the regulation is in its infancy, and many health organizations are yet to meet the criteria that are set. So that's important to be aware of in your country. The United States has laws, Europe has laws, they're all different. Everybody's laws and regulations are different from one another. They're all intended to protect the patient, to protect the individual, but they do it in very different ways. And as is implied in this question, they're very early in many cases. In the United States, we have a law called GINA, the Genetic Information Non-Discrimination Act. It's a whole law essentially now that says you can't discriminate against somebody because of their genetics, because of the mutation that they have, and you in terms of health insurance or employment or things like that. And so those are things that probably don't exist in many parts of Africa, but those are coming along, and they should come along. There should be frameworks around which genetic information is used and understood so that the patient is protected. There is another question about ethical issues around genetic testing. How's the sample kept? What are the limits? Gene profiling, which can be more than just cancer genetics. I think that this is, again, there are standards that have been developed for what you do with the residual sample, what you do with the data, how they're stored, what the confidentiality is. And I think that, and I'm going to ask each of the speakers to say a word or two about that, but these standards are developing, and they are certainly things that require some ethical discussions with ethicists, with regulatory agencies, with health systems and things like that as the work expands and the capacity expands. So I don't know if any member of the panel wants to make some other comments related to that. No, you need not, but I think these are areas that will require development and additional discussion among policymakers. And so that's something that we really need to keep in mind. I apologize, we are at the limit of our time, and there are a number of really good questions that I wasn't able to get to answer, but we'll try to do those by email with some of the others. And keep some of these questions in mind. Maybe we can answer them. You can ask them again in the coming sessions, or we can try to answer them. Some really great discussion. I want to thank our panel, who's been just very informative and helpful. And thank you all the attendees for taking part. And remember, tomorrow, the same time, the same Zoom links for the discussion about genetic testing itself with our colleague from Invitae. So I look forward to seeing you tomorrow. Thank you.